Hello and welcome to the topic Gout in the Rheumatology module. By the end of this topic, you should be able to define gout, discuss the causes and pathophysiology of gout, describe the clinical features of a person with gout, outline the investigations to support the diagnosis of gout, discuss the principles of management, and lastly, elaborate the complications of gout and its treatment. Let's get started. The term gout was derived from the Latin word gutta, meaning a drop of liquid. It refers to the dropping of a morbid material from the blood in and around the joints. Gout is the most prevalent form of inflammatory arthropathy. It is a form of microcrystal synovitis caused by the deposition of monosodium urate monohydrate in the synovium, and this is caused by hyperuricemia. Hyperuricemia may be associated with both hyperlipidemia and hypertension. It may also be seen in conjunction with metabolic syndrome. Hyperuricemia may be found in asymptomatic patients who have of gout. There are well-known risk factors for gout, and these include the male gender. Men are more likely to develop gout. Next would be age. The risk increases with age, and most commonly the first attack appears between ages 30 to 50. The next important factor is diet, which is high in purine. These foods are meat, alcohol, and fructose-containing foods. Increased purine levels lead to increased uric acid production in the body as purine is metabolized to uric acid. Certain medications are also associated with increased risk of gout, and these are loop diuretics, thiazide diuretics, pyrazinamide, and low-dose aspirin. The etiology of gout can be broadly divided into the under-excretion of uric acid via the kidney and endogenous overproduction of uric acid. Purines which are obtained from the diet are broken down into uric acid, and the final pathway is catalyzed by xanthine oxidase. So reducing purines can reduce serum uric acid and eventually reduces gout. The interesting part of gout is that it develops rapidly, reaching maximum severity within 24 hours and resolves within 5 to 15 days. An attack of gout is triggered by a sudden change in serum uric acid, and this can happen following rapid weight loss or fasting, use of radiocontrast dyes, and medication changes. Commonly, the first presentations involve the first metatarsophalangeal joint, but sometimes gout may affect other joints of feet, ankle, and knee as well. Typically, those affected complain of intense pain, often described as stabbing and very painful. And this can even disturb them from sleep. Other features include erythema and joint swelling, which results in reduced range of motion. Look for systemic symptoms, which may include tophies. Tophies are monosodium urate crystals that deposit to form small hard lumps in the tissues surrounding the joint. The European League Against Rheumatism recommends that clinical diagnosis be supported by the following features, which include monoarticular involvement of a foot or ankle joint, previous episodes of a similar nature, the condition on rapid onset, erythema, as well as the male gender. NICE guidelines state that if a patient presents with features suggestive of gout and there are no suspicions of other conditions such as septic arthritis, a clinical diagnosis can be made with no need for investigations. NICE also advise aspiration is not indicated unless diagnosis of gout is unsure or septic arthritis is suspected. Fine needle aspiration of the affected joint is considered the gold standard, as the presence of monosodium urate crystals is 100% specific for gout. Usually, synovial fluid in gout will contain white blood cells at a level greater than 2,000 cells per microliter. It can also be used to differentiate between gout and pseudogout. Additionally, synovial fluid analysis allows the exclusion of an infective arthritis. How about serum uric acid? So hyperuricemia is not diagnostic of gout, but increased levels do correlate with increased risk of developing gout. Ideally, serum uric acid should be measured 4 to 6 weeks following an acute event to confirm hyperuricemia. Remember, the absence of hyperuricemia does not exclude gout. Radiological features of gout include joint effusion, which is an early sign, well-defined punched-out erosions with sclerotic margins in a juxta-articular distribution, often with overhanging edges, relative preservation of joint space until late disease, eccentric erosions, no periarticular osteopenia, as well as soft tissue tophi may be seen. And for acute management, NSAIDs are first line in conjunction with gastroprotective medication. NSAIDs should be avoided in elderly patients taking warfarin due to the risk of a life-threatening gastrointestinal hemorrhage. NSAIDs should be avoided in impaired renal function and congestive cardiac failure. Colchicine is the next drug that we'll be discussing. It has a slower onset of action. It's safe to use in renal impairment. It's effective when given within 12 hours of symptoms onset at a loading dose of 1 mg, followed 1 hour later by 0.5 mg on day 1. It inhibits microtubule polymerization by binding to tubulin, interfering with mitosis, also inhibiting neutrophilic motility and activity. It may be increased up to a dose of 3 mg and divided in 600 micrograms portions to cope with the acute attack. It's useful in patients taking warfarin as combined NSAIDs with warfarin may be harmful to the gastrointestinal tract. The main side effect is diarrhea, increased risk of myopathy if co-prescribed a statin. Next would be corticosteroids. Corticosteroids are highly effective and can be used where NSAIDs are not tolerated or in refractory disease. Intra-articular steroid injection here can potentially cause certain local side effects, and these include increased pain for the first couple of days, septic arthritis, subcutaneous atrophy, skin depigmentation, and accidental nerve injury and tendon rupture. Interleukin-1 blockers are approved anti-interleukin-1 monoclonal antibodies for patients with contraindication to colchicine, NSAIDs, and steroids. Rasburicase is a recombinant urate oxidase, may be given during the acute attack of gout to allow allopurinol therapy to be commenced without initial worsening of symptoms, but it's not currently licensed for the treatment of acute gout associated with other conditions, and this is a good choice for warfarinized patients. The British Society of Rheumatology guidelines now advocate offering urate-lowering therapy to all patients after their first attack of gout. Urate-lowering therapy is particularly recommended if there are 2 or more attacks in 12 months, if there is presence of tophies in renal disease patients, those with uric acid renal stones, and as prophylaxis if patients are on cytotoxics or diuretics. How about the management of chronic gout? Well, the EULA recommends allopurinol as the first-line urate-lowering therapy with target uric acid levels of 360 micromoles per liter or less. It is a xanthine oxidase inhibitor, metabolizing xanthine to uric acid, and this results in reduced deposition of monosodium urate crystals in the joints, hence the development of gout. And it's generally well tolerated, but side effects may include common side effects such as skin rash, and this may indicate Stevens-Johnson syndrome with joint pain or swelling, as well as rarer side effects such as drug hypersensitivity syndrome, and this is characterized by eosinophilia, lymphadenopathy, fever, and multi-organ involvement. Now, there are some lifestyle modifications that can be suggested, such as reducing alcohol intake and avoiding during an acute attack. Also, if one is obese, losing weight would be beneficial. Avoiding food with high in purines such as liver, kidneys, seafood, oily fish, and yeast products. And finally, to avoid sugar-sweetened drinks and foods that are rich in fructose. Other points to remember would be consideration being given to stop precipitating drugs such as thiazides. Losartan has a specific uricosuric action and may be particularly suitable for many patients who have coexistent hypertension. Increased vitamin C intake may also decrease serum uric acid levels. Let's take a look at allopurinol interactions. So allopurinol interacts with azathioprine. Azathioprine is metabolized to active compound 6-mecaptopurine, and allopurinol can therefore lead to high levels of 6-mecaptopurine. A much reduced dose must therefore be given in combination. Allopurinol increases toxicity and effects of azathioprine and 6-mecaptopurine. So reduced dose of azathioprine and 6-mecaptopurine in 1/4 of usual dose. In the event one is using cyclophosphamide, allopurinol reduces the renal clearance of cyclophosphamide. Therefore, this may cause marrow toxicity. Finally, for warfarin, allopurinol can interact with warfarin to enhance the anticoagulant effect of warfarin. Allopurinol increases INR by inhibiting the metabolism of warfarin. Alright, a quick recap. Gout is a type of inflammatory disease that typically affects the first metatarsal joint, which is the base of the big toe, where uric acid precipitates to form monosodium urate crystals, which then deposit in the joint and lead to inflammation, such as evidence of pain, redness, warmth, and edema. Over time, chronic gout can lead to bone erosion. The diagnosis is based on synovial fluid analysis where monosodium urate crystals have sharp, needle-like form and are negatively birefringent. Acute management is aimed at pain and inflammation control. Allopurinol is the first-line urate-lowering therapy agent that's given. We have come to the end of this topic. Thank you.